Hi, everybody. Can you hear me? Great. Okay. I'm Joanna Katzman. I'm a neurologist at Project ECHO and UNM. Welcome, everybody, to our infectious disease office hours. It is May 10th, 12 noon Mountain Time, and welcome to this weekly session with Dr. Nestor Sosa, Dr. Leslie Hayes, and the rest of our team. Wanted to remind you to keep your line muted and turn your camera on if you have that opportunity. It's perfectly all right to eat and drink. For many of you, it's your lunch hour. Please be reminded that Kent Noseworthy, our digital librarian, will be putting in evidence-based and evidence-guided material into the chat. And I think you will enjoy getting that material. And then 45 minutes after the hour, you can get the CME link. And even if you don't need CME, please fill that out. We do look at that at least once a month and see how you are all doing and see how we can improve these sessions. So without further ado, I'm going to turn it over to our leader, Dr. Nestor Sosa, who is a professor in the Department of Internal Medicine, the infectious disease lead, and he's our great champion here. And he has a presentation followed by Dr. Leslie Hayes. Thank you.
Thank you very much, Joanna. So yes, I'm Nestor Sosa. I'm the Infectious Disease Division Chief here at UNM. Let me share the screen. Put it on presentation mode. Okay, so yeah, so today I'm going to review several articles. Some of them are somewhat extensive, so I'm going to be quick. This photo, I just want to make reference to this photo. I found in one of the articles, the pink dots here are the coronavirus, and this is like the surface of a cell. So you have an idea how many viruses are, trying to enter or attaching on this cell. I thought it was a nice photograph. So start with some good news before I give you some bad news. Essentially, this is the graph that I actually got from Dr. Shan update that she does here at UNM on the COVID hospitalization in the US. And you can see obviously that there's a significant decrease if you compare with like November, December, where we were in hospitalization and where we are. And I'm showing this because I just read an article on MNWR on the forecast for the next few months. And it was somewhat disappointing. And I'm going to go through that article. Actually, this is the name of the paper, Modeling of Future COVID-19 Cases, Hospitalizations, and Death, according to vaccination rates and NPI, the non-pharmaceutical intervention. And actually what the CDC did, they actually invited 6 different modeling teams from, throughout the United States. They gave them some general guidance on how to create some potential scenarios. And then these 6 modeling teams actually did a prediction on what's going to happen with the cases, hospitalizations, and death from COVID-19 in the next few months here in the US. And these are some of the assumptions. They actually have like a four scenario. They put high vaccination or low vaccination, and then moderate MPI or non-pharmaceutical interventions, and low. So they have 4 possible situations: high, low, or low, high. So as you may imagine, and these are the definitions of what they consider a high vaccination or a high MPI estimation. And what I found surprising were the results. In all of these exercises, they actually calculated the 4 scenarios, and you can see here the low vaccination, low MPI is obviously the solid line, and then low vaccination, moderate. And in all cases, they predicted sort of a surge in late May, early June. Despite the effort to vaccinate people, even the most optimistic scenario, which is the one with the line and the dot here, still there's a minimal increased number of cases. Obviously, if no intervention is done, there are more cases, which could be close to 40-50 cases per week in the beginning of June. But the good news, if you're an optimist, is that even in the worst scenario, the cases are going to go down right before the fall. But obviously, this study underlines the importance of continuing some type of non-pharmacological intervention as we move forward with the vaccination effort, and how important it is to try to convince people to get vaccinated, because in several of these scenarios, we're going to have a small surge in the number of hospitalization and cases, and these are the number of deaths also with the same shape. And this is really consistent among all the different modeling groups that did this exercise. So I think that's the message of this interesting publication. There are some other details, but I wanted to highlight that we certainly need to continue the effort in getting people vaccinated and getting some type of MPIs until we're really out of the woods or completely out of the pandemic. The other article that I want to mention, it's about a new vaccine. I think several months ago, I actually presented some data on the Novavax vaccine, and we haven't really talked about it a lot because, all of the headline has been all of the Pfizer, Moderna, and AstraZeneca and Johnson & Johnson have got all the attention from the publication, but I think Novavax is another vaccine. And just as a refresher, this is a recombinant protein vaccine that actually uses the spike protein, and the way they make it is really interesting. They use cells from an insect, and they infect it with a baculovirus, which is a pathogen of insects, and they include in the baculovirus the gene to synthesize the prefusion conformation of the S protein. So basically the cells start producing this S protein, which is the surface protein from the SARS-CoV-2. And then this because it's just a protein, they usually combine it with a plant-based, a saponin-based matrix M. And I think I presented this paper, but the way they look under the microscope, the spike protein arranged themselves in this rosette, this nice looking, almost like a small flower, and this is the saponin matrix. So it's a different sort of a cage, and this is the way that this vaccine is formulated, with this adjuvant and then the rosettes of spike protein, and that's what's administered. So the study was actually published in the New England Journal, and it's they actually published the data of the Novavax vaccine in South Africa against the South African variant, the B1351. And what's interesting, well, they enrolled mostly young patients. So there were like 4,000 patients in this study, 2,000 in every group, in the vaccine group and placebo group, and they used one dose of the Novavax vaccine in this relatively young population. And the main finding was actually the efficacy was around 50%. So, and this is again, most of these patients had the South African variant. So this is comparable to some of the other studies with this variant, which is one of the most troublesome. And they actually divided patients because, as you know, in South Africa, there's a very high prevalence of HIV. So they divided the cohort among HIV positive and HIV negative. And among those who are HIV negative, the efficacy was around 60%. So slightly better than the general 50% efficacy, because that included some HIV patients. And these are the graph, basically the placebo and the vaccine. We are now used to seeing this graph. It was better, obviously, in those HIV negative. It was more of a separation between the cases in the placebo, which keep going up, as opposed to the Novavax vaccine, which the cases are kind of flat. But one of the most interesting findings of this study was what happened in the placebo group, and is that those who receive a placebo, if they had COVID or did not have COVID, they have the same incidence of COVID-19, which that means that if you had COVID before, with this variant, there's no protection. So that it was really surprising and interesting that you had the same risk of developing COVID if you were not vaccinated. This is like the natural history of the disease. People exposed to this new variant were as likely to get COVID again as those who had COVID already. So this basically in this well-designed study to prove the efficacy of the vaccine, they found this, sort of serendipitous finding that actually you have no protection. And this is basically the timeline of the different variants in South Africa. And you can see the square here, or the rectangle, is where they did the study. Most of the cases were obviously due to the variant, to the 501v2 variant, which is the South African, also known as the 351. So, but this finding was kind of impressive, that there's no protection against this 351, even if you had COVID. So if you were in the placebo, same incident, which was interesting. The other vaccine study that I want to share with you, and this is something that we have asked: do immunocompromised patients develop antibodies after vaccination? Are they protected? And we are already starting to get data on this, published data, and this is a publication from Johns Hopkins, in which they measure the antibody production in patients who had received solid organ transplants before, so included liver, kidney, lung, etc. This was the publication is a research letter, and from Johns Hopkins, and what they found, and let me take you through to this table. They basically noticed that there were three types of patients who did not respond at all to the 2 doses of the vaccine, those 1 negative, those 2 negative, so no antibody response, those who actually responded to the second dose but not to the first, and those who responded to both. So if you want to just simplify, like around 54% of these patients had a good antibody response, 46 did not. So obviously this is much less response as compared to immunocompetent patients, where the response are 99, 98%. Almost everybody mounts a good antibody response, and then the efficacy we know in clinical trials is around 94 to 95%. And this is mRNA vaccines. So that was the first phenomenon. So obviously, these solid organ transplant patients that are taking immunosuppressive, they just barely half of them, a little bit more than half of them, actually react to the vaccine, and some of them have no reaction to the first dose. So a large percentage have no reaction, but finally with the second dose, they got a better response. Obviously, there is sort of an age-related relationship. The older you are, the less likely you are to respond. It's always this way. So almost 50% of those over 60 had no response. So a little bit less than the whole group, the group as a whole. There was no significant difference in the gender response. And other factors was the type of organ. The worst response was probably lung, with 61 having no immunity or no antibody production. Obviously, the pancreas it was very small, the number, 80%, but there were only 4 patients. But definitely, if you have lung compared to, let's say, liver or kidney, that had a better response overall. And also and this is something that we know from infectious disease and from transplant medicine, that the longer you are from your transplant, the better you are. So you see like those who were less than 3 years had a 63% non-response, as opposed to those who were more than 12 years had only a 33% non-response. So obviously, if your patient is recently transplanted and was vaccinated, he's more susceptible to have COVID because the lack of response of the antibody. So I really like this trial. It was around 658 transplant subjects. It was not thousands of subjects, but it starts to tell some story about it. And then there was also a difference. I'm sorry, I forgot to mention about the difference. If the patient was on mycophenolate or one of these antimetabolites, either mycophenolate or azathioprine, the response was much less than if it was only on prednisone and cyclosporine. So there's also a difference of what they are receiving currently to the degree of immune response to the vaccines, to the mRNA vaccines. The other paper that I'm just going to summarize in one table is the durability of humoral immune response to SARS-CoV-2. This is it's going to be published in Cell Reports, and I just like the graph of these, the summary graph of this paper, which was sort of a complicated immune paper. I'm not going to go through all the details, but to make a long story short, this is sort of the evaluation of the humoral immunity response to SARS-CoV-2 as measured by antibodies against the spike in patients who had the natural infection. And to make a long story short, both the memory B cells and the IgG anti-spike antibody lasts for at least 6 months. What we lose relatively early are the IgM, as you might expect, and the neutralization. Okay, but at least there's evidence of sort of a long-lasting 8-month, in this case, 31, 32 weeks um, of the antibody producing B cells and also some of the antibody cell cytotoxicity. So these are probably the longest, follow-up publications on the natural infection duration of immunity, which is already around 8 months, according to these authors. And finally, it's been a while since I have presented anything on therapy. We have really concentrated on vaccine, but I thought it was important. You remember the recovery trial was the one that gave us the dexamethasone recommendation. Is this a real life or close to real life trial that they're doing in the UK with thousands of patients randomized to different arms. So now they finally published, because I have seen this in pre-publication, but they finally published the IL-6 inhibitor tocilizumab in hospitalized patients, and actually is the second drug that clearly demonstrate decreasing mortality. Together with the dexamethasone, now we have the tocilizumab, and a high percentage of patients were receiving. So I'm going to go through this trial. So it was published in the Lancet a few days ago, tocilizumab in patients admitted to the hospital with COVID. So these were all sorts of patients with COVID diagnosis, and you can see these are the two groups. So 63 years is the mean age, so they were sort of the high group, and in fact they had like almost 1/4 of them were over 70. So this was definitely different from the vaccine study we saw from South Africa. And there was also a significant ventilatory support. So more or less 50% of the patients with either in non-invasive ventilation or already on mechanical ventilation. So these were patients with, fairly severe or advanced COVID infection or COVID-19 infection. They ended up randomizing 2,000 in each arm. So conventional therapy versus tocilizumab. And this is all the whole design, the whole recovery, if you remember, was over 20,000 patients. And these are all the arms, colchicine, azithromycin, et cetera. But this is just concentrating on the tocilizumab. And to make a long story short, they found a benefit, modest, but a very solid difference in the mortality and also in the possibility or probability of being discharged alive. So two positive outcomes. And you can see the Kaplan-Meier of being discharged alive, always better with the tocilizumab group compared to the standard of care. And then it was also consistent across all patients, age, gender, racial or ethnicity, if you were on ventilator support or not. There were, most of these findings were to the left, favoring the tocilizumab, and obviously the overall benefit was with a risk ratio of 0.85, so means 15% better probability of survival at 28 days with the tocilizumab. And then numerically, so it was 15% for 28-day mortality, a 22% better chance of being discharged. Also, there was less risk of renal failure and less risk of developing or going on to the need mechanical ventilation. So a pretty positive, not dramatic. We're not talking 80% decrease in mortality. We're talking 15 to 20% decrease in all these risk factors, but nevertheless, something better than we have seen with other drugs like hydroxychloroquine. Even remdesivir has not been able to prove decreased mortality overall. So that was a positive. And this is sort of a summary of all the studies. Now with the recovery added to all the studies of tocilizumab, we can see that this forest plot is to the left. So there's some benefits. So I think people, after they have time to digest this recovery study, I think some of maybe the NIH or the IDSA will move toward a more recommendation of this tocilizumab in the future. That's sort of my guess, especially for patients who are hospitalized with increase in inflammatory markers. And finally, just one graph about the B117. Before we presented this data here at the office hours, we said that there was a fight between the B117 and the California strains. Now, the most recent data on on our or the strains or the variants of concern, you can see that now the light orange B117, it's almost 60%. It has really defeated the 429, one of the Californian strains, and some of the older original strains. So now this is the most common throughout the United States, and it's also the case for New Mexico, according to the group that is working on this information here in the Department of Health, in UNM, and the national laboratories. Okay, I think that was it. Thank you. Thanks.
Thank you, Dr. Sosa, so much. Wanted to quickly turn it over to Dr. Leslie Hayes, our primary care and addiction specialist.
Hi, thank you. So Dr. Sosa, I think you need to convince the ID folks to come up with a different name than either the B117, because those are too hard to remember, but I agree that the place names are not correct. So I think maybe name them like they do hurricanes, name them after, people or something, but we need a different naming system for them. So
I agree.
So there were some questions last week about vaccine hesitancy. So I'm going to talk today about how to address vaccine hesitancy. And just some general advice if you're trying to talk to patients about vaccine. First off, all of this works better if you have a positive relationship with the person you're trying to convince. Don't even bother with Aunt Muriel, who thinks you're an idiot because of who you voted for president last year. It's just not good. Really focus on people you already have a good relationship with. Second is to try to really listen. And you don't want to listen with the idea of refuting their argument but you really want to listen and attempt to understand their concerns. And I must say that this one actually, when I was in college, I was having a political argument with someone. I don't even remember what it was about, but I remember that person sat down and listened to me for about 15 minutes and then recited my argument back and then said, I still don't think I agree with you. And that persuaded me to their point of view better than anything they could have said. So if you really understand people's concerns, it really does go a long way to being able to talk to them about it. Know the science and be prepared to discuss it, but also use anecdotes. People really like anecdotes. And it's been shown that it actually helps to get people to take things more seriously. So have anecdotes both about COVID, patients who've gotten really sick or developed long COVID, and also anecdotes about the vaccine. And motivational interviewing is really great in this scenario. I found this wonderful article about something called the CASE approach, which I'd never heard of before. It was published in Minnesota Medicine in the March and April issue. And CASE stands for corroborate, A is about me, S is science, and E is explain and advise. So basically, first off, you do what we already talked about, which is listening very carefully. And then you frame a response that corroborates what they've said, sort of discussing what their concerns are. And then you make an about me statement, which is sort of how you feel about it, how you approached it. Then S, you talk about the science underlying the recommendation and or explaining their concerns. And then finally explain your advice to the patient. And I'm going to give an example, but I really encourage you to go read the articles because they've got about 6 different examples of how to use this. And it was just so helpful. So patient who feels like the vaccine was rushed. I'm hearing this one a lot. First off, you sort of corroborate. So it does seem like the vaccine came out very quickly compared to the usual time course for vaccines. And then say about me. So I say, I truly was a little bit worried about how quickly it came out until I did some reading. And then I talk about the science. When I did the reading, I discovered that they actually went through all the steps they usually do for vaccines. They just did it a lot more efficiently than usual because of the urgency of the situation. And then explain and advise, as your doctor, I feel the vaccine is safe and they've done adequate study when you get it. And like I said, you might want to look at the article because it really was a very helpful article on explaining how to use these. And then some specific arguments that my COVID physician group has come up with online that I thought were useful. We don't know the long-term effects of the vaccine. And while this is true, vaccines rarely cause long-term effects. And we do know that COVID causes plenty of long-term effects, including lung disease, heart disease, diabetes, and neurological symptoms. And people who talk about the death rate is low for younger people, again, talk about the long-term effects. And then I find this the most puzzling argument that people, but I hear this from people a lot. I have a lot of health problems. I am afraid the vaccine will make them worse. course. And so with these, help to talk about the patients may feel bad for a few days, but it's rare that the vaccine causes any long-term worsening of health problems. And they are at significant risk of problems from COVID if they get it because of their health problems. And then this was another one I really liked. I'm young and I'm unlikely to get sick from COVID. What does it matter to me? And people said they've had really good success talking with about, as long as young people are getting COVID, they will be passing it on to more vulnerable people. And we're going to have to continue the restrictions. The sooner we can get sufficient number of young people vaccinated, the sooner we can begin to lift the restrictions. And people are saying they've actually had pretty good response to that particular argument. And then I was a little embarrassed this last week. One of my patients called and she said, I don't know if I want to get this vaccine. They said it's not FDA approved. And so I was able to sort of go through and explain to her why, I still felt it was safe, but I realized I didn't fully know the difference between FDA approval and emergency use authorization. Unfortunately, I was reasonably close. And this is from the FDA website. And emergency use authorization means that they feel there's good enough data, but there's not as much data as would be needed for FDA approval. But they do have to have enough data to say that the intervention is safe and effective for its intended use, and that the product can be made according to federal quality standards. And they carefully balance all the potential risks and benefits of the product. So even though it's not quite as strong of data as needed for FDA approval, it's still pretty strong. And then this was very, very interesting. This woman is Heather Simpson, and she was a big anti-vax advocate in Texas for a few years. And she ended up deciding she wanted to get the COVID shot. And so this article was just about her and why she decided to get it. And then I think I've mentioned your local epidemiologist. She actually did an interview with her. And it's well worth reading just to kind of understand sort of the anti-vaccine mindset. And there were a few things I got out of this from reading what she had to say. So Heather Simpson became an anti-vaxxer. She was, I think, considering or had just gotten pregnant and wanted to learn a little bit more about vaccines. And she said she ended up watching a 9-hour documentary that she found on Facebook. And she said she was especially convinced when she found a half dozen anti-vaccine doctors. And I really like the anti-vaccine or kind of meth vaccine doctors are very, very harmful because people really do pay attention to them. And she said, if you're at all prone to fear, it was very hard not to be convinced by this documentary, which really, went after the fear. And so she said she posted a mildly anti-vaccine post on Facebook, and she received many friend requests from anti-vaccine advocates. And she also said she got a lot of vitriol from pro-vaccine forces, and she states this solidified her anti-vax resolve. So, think about it. If you see an anti-vax post, maybe not attack the person because that often can push them further into the other camp. And she said eventually she got frustrated because people were just opposed to anything medical, and she had needed something medical, and she started looking at the other side. And she actually pointed out there's a spectrum from vaccine hesitant to extreme anti-vax. And she said, sort of first is vaccine hesitant, then people who are just scared, but not necessarily going one way or the other. Ex-vaxxers are people who had vaccinated their kids, and their kids afterwards developed something such as ADHD or autism spectrum disorder, and they didn't have a good explanation for it. And so they just chose the vaccines. Then there are the people who are 100% natural, don't want to do any supplements. Light conspiracy theorists, and then what she referred to as the lizard people, who are sort of extreme conspiracy theorists. And she said for the people who are just scared, often just getting them the facts. And if you can get them the facts before they've really gone down the anti-vax rabbit hole, it can be very helpful. So these are the people who often will respond to facts and understanding how things work. For the ex-vaxxers, one thing she said, and this is obviously not a short-term solution, but we need to get alternate explanations besides the vaccine for why children are developing autism spectrum disorder or ADHD or some of these other conditions. Because right now, often we don't have a good explanation for why children develop these. And so it's easy for people to latch onto vaccine. 100% natural, the people who won't touch any pharmaceuticals. I must admit, I haven't had great success with these. Although some of them, I do find it interesting, won't take the vaccines, but they will take antibiotics then for these conditions when they get them. And so I will talk to them sort of about what I view as the risk to antibiotics and why I'd take 50 flu shots over an extra course of antibiotics. And that can sometimes be helpful. Light conspiracy theorists, I have found that sometimes will respond to actual conspiracies on the other side. And one thing, and I don't remember where this was, but the media literacy group out of Albuquerque several years ago had a video where they taught teens about cigarette advertising and sort of all of the manipulation and everything that goes into cigarette ads. And it made them very strong anti-tobacco advocates. And so realizing that, because initially they kind of thought there was a conspiracy from smoking, but then they realized the conspiracy was actually from the tobacco companies. And the extreme anti-vaxxers are probably not worth spending a lot of time on at this point, because you're probably not going to make much of a difference there. And then paid people. And I was unable to find actually the original research that this article from the New York Times was based on. But it was based on data from the UCLA COVID-19 Health and Politics Project. And so they said, if we give you $100, would this make you more or less likely to get a vaccine? And 34% said they would be more likely. 15% actually said they'd be less likely, because they were like, oh, if they're paying me, there must be something wrong with it. So you increased it about 19% if you offered people money for it, a little bit less if you offered them less money. And then they also found that the possibility that you could go without a mask was an incentive, but interestingly, people who are unvaccinated often don't think they need a mask. So if you looked at the likelihood of people getting the vaccine if they no longer had to wear a mask versus still having to wear a mask, it went up. They divided it out by all these different groups. It went up the most in Republicans, more in white people than Black people. Overall, people were 13% more likely to get the vaccine if they thought they could stop wearing a mask. But interestingly, the number of people in the last 2 weeks who dined at a restaurant who were not vaccinated was 53%. Fully vaccinated, 32% of them dined at a restaurant. Gathering outdoors with more than 10 non-family members. Again, the non-vaccinated were more likely to do that. So they need a mask to begin with, so that may not be much of an incentive to get them vaccinated for a lot of people. And then some interesting articles, evaluation of and management of COVID-19 in pregnancy and contemporary OBGYN was just good summary of all the literature on COVID-19 and pregnancy. And in my family, my daughter got Pfizer, so she refers to herself as Team Pfizer. Most of the rest of us got Moderna, and my son got Johnson & Johnson. And we have all sorts of ridiculous arguments about who's the coolest because of which vaccine we got, but this was a pretty funny article about why Johnson & Johnson is the coolest. And then this was a nice article by, I believe she's either a pediatric infectious disease doctor or pediatric hospitalist, I can't remember which, on kids' vaccines are on the way and why parents should get that vaccine if you want to show it to any of the parents in your practice. So, and that was everything I have.
Thank you, Dr. Hayes. Fantastic, really good skills and communication points for us all about vaccine hesitancy. And I wanted to introduce Dr. Cecilia Thompson. Cecilia, are you there? Cecilia is one of the medical directors at Tricor.
I am here. I don't have anything to update today, but I'm happy to take any questions regarding testing.
Fantastic. Thank you, Cecilia. And I think we don't have Marla Sievers on the call just yet today, but I'm going to turn it over to Dr. Thornton.
Thank you, Joanna. Hi, everyone. Carla Thornton here with Infectious Diseases at UNM. Nice to see everybody. So we have a bunch of questions. I'm just going to start from the earlier ones. This can be for either of you. Dr. Alan Carreau was asking, will New Mexico pursue herd immunity as others give up on that goal? Any thoughts about that?
So Dr. Fauci actually had an interview on NPR last week, and he said, no, we're not giving up on herd immunity. He said the problem is it's just hard to have that as your goal because we don't really know what the threshold is. And he said, our goal is still to vaccinate as many people as possible. So it's not like they've given up. It's just sort of, they've changed the goal to just being, let's just keep vaccinating and figure out how to get as many people as we can vaccinated.
Thanks, Leslie. Nestor, anything?
No, I mean, for me, it's like saving money for my retirement. I mean, I'm not going to say I'm going to save $1 million. If I save $1.5 million, I'm happier if I save, 2 million. So I think you have to make the best effort to vaccinate as many people as possible. You're not going to stop at 65 or 70 or 75. Just get everybody vaccinated and we get this over. I mean, the herd immunity is just a concept, an epidemiological concept, But in reality, the reality is that you try to vaccinate as many people and fight hesitancy, etc. I think that's the key, not obsess on a number.
Thank you. Nestor, in reference to the information you gave about the transplant patients, Leslie Hayes was asking, should we check antibody levels in patients with organ transplant after vaccine to document immunity?
Sorry, yeah, I haven't really thought about it. But if anything, it would be in that population. If you're going to measure in somebody or in some group, it would be immunosuppressed to see. But we need to have a correlate of protection, which is I'm not sure we have a complete clear idea that what level of antibodies protection and which one is not. It's a little bit more complicated. I mean, there have been efforts by research groups to try to find a correlate between neutralizing antibodies and vaccine efficacy, but it's hard, when there's so many commercially available, and maybe Cecilia can make a comment on these too, to say, okay, you have whatever 3.5, level of antibody that's protected or not. It's kind of hard for me to find that magic number.
Go ahead, Cecilia.
Yeah, and I'll just add that there are diagnostic tests available to determine whether you have antibodies that are due to vaccine or due to natural immunity. But Nestor's right, there's no cutoff for whether this is a protective level of antibody or not. Those studies are still ongoing, so they're not part of the diagnostic test.
Thank you very much. John Foster asked a really interesting and important question. Can you explain the mechanism of why vaccines appear to provide better protection than natural infection, which doesn't seem to be the case for most other infectious diseases?
Right. I can try to speculate a little bit based on what I have read in especially the discussions of the papers about immunity, and is that the natural infection, when you're dealing with the virus does have like inhibitors of the immune system. So the virus tries hard to fight your immune system, and there are like proteins in the virus, especially the open reading frame that antagonize the interferon, etc. So you do not mount a perfect immune response, as opposed to when you were vaccinated and then you have a booster again. There is a more robust, specific antibody with all the anti-immune system proteins that may be playing a factor when you are sick with COVID. So that's the best explanation that people can come up. And another reason for getting the vaccine, even if you have COVID, you have to get a dose of the vaccine, and then you mount a more robust immune system, because the virus doesn't allow you to mount the ideal immune response, because that's part of the mechanism in which he's successful, causing disease, impairing your ability to respond to it.
Great, thank you, Nestor. I'm going to see if Julie Brockmeyer, if you have audio, can you unmute yourself and ask your question?
Yes, my question was in regards to the recent recommendations for how soon after being positive with COVID, you should get the vaccine. I know that the CDC has said 90 days. I know that I've also heard 2 weeks. I am talking about a patient without comorbidities who was non-hospitalized, but still has myalgias and fatigue 3 weeks out.
Right, that's a good question. I don't think we have like a definitive answers, and I've seen two schools: those who recommend vaccination as soon as possible in order not to miss an opportunity to vaccinate. So if you have somebody who's under your care and had COVID, let's say a month ago, you can probably vaccinate him right there. If you think he's going to be lost to follow-up, or you're not going to see him again, because there's no absolute contraindication for vaccination. The idea of the 3 month, it's number one, because that person, presumably during those first 3 months after COVID, it's somewhat protected from having a reinfection. So there's no rush. And if you want to use that dose on an unvaccinated people or person, it's even better, because you're using the dose more rationally on a person who has zero protection versus somebody who maybe has an 80% protection from the natural infection. So that's the other reason. I recently, actually last week, I reviewed a paper in which for the first time they tried to see the immune response on those who had COVID in association with the time when they were vaccinated. And there seems to be like a sweet spot after a month of having COVID, you get a better response, a better antibody response. So if you get the vaccine too close to the acute infection, you're not going to mount a pretty good antibody level. So there's some data now coming out that probably you have to wait a little bit, at least a month, but you can safely wait, more than that, because you're protected from a reinfection. So from a sort of a epidemiological point of view, you can wait up to the 3 months, which is from some of the recommendation. So, but that's the data that we have.
And the second part to that was, I have heard, and I don't know if this is anecdotal or not, that sometimes getting the vaccine will cure those symptoms.
Right. Yeah, that's another good question. For people who with long COVID, there have been a few studies that are showing that after vaccination, patients with long COVID symptoms, a percentage, not all of them, and it's not, like super dramatic. There is a percentage of them who actually improve, and there's no evidence that they get worse. So the it's not 100%. The paper that I review is more around 25% of those who had long COVID had an improvement in their symptoms. Obviously, if you're one of those, you're going to say, "Oh, I got much better when the vaccine." But there's some other in the surveys that actually didn't improve dramatically after vaccination. But there is at least the reassurance that most of them got better, or at least didn't get any worse.
Thank you, Julie, for those great questions. Nestor, Harry Seibold had a question about, it looked like on your slide in the tocilizumab study that the people that were older than 80 years of age did not have benefit. Is that correct?
Yeah, I would have to go back to the paper. I don't remember, and I'm wondering if that is because of the small number of patients in that group. I would have to review the slides. Let me go back here.
Okay, and while
yeah, it was to the left. Just to answer, it was to the left of the graph. It's just that it crossed one. The confidence interval were basically crossing one, but the mean was to the left, so it was beneficial. But it was too broad of a confidence interval because of the number of subjects in that group.
Great, thank you so much. We have a question about the Brazil variant. Any information about that, Nestor, that you have?
No, I review. I mean, we review here a couple of papers on the immune response, and there is an immune response, and they're neutralizing antibodies. They are not affected. The neutralizing antibodies, especially the mRNA vaccines, induce antibodies which are in between the UK and the South African. So the Brazilian in the antibody levels, it's sort of in between. The worst case scenario would be the South African, which is the one that you generate less of a neutralizing antibody. The UK seems to be almost unaffected by regarding neutralizing antibodies. So the Brazilian seems to be in between the two, the South African and the UK variant. But that's the only thing I have seen. Obviously, there is a concern on the ground in Brazil because they're using one of the Chinese vaccine, the CoronaVac, that is not very effective. But this is just anecdotal. I mean, we don't have data on efficacy specifically against the Brazilian strain in clinical studies.
Thank you. I wanted to see also if Anne Corliss Lane, if you have audio, if you can ask your question, because it has several different parts to it. And if you can, just introduce yourself.
Sure, my name's Anne Corliss Lane. I'm actually an infection preventionist nurse in Michigan. So I've been doing a lot of studying with virology and just trying to learn about the whole process of the mutant virus. And what I've been trying to research is if there's actually any clinical studies proving that those variants are more contagious, or do they have a higher binding affinity with the ACE receptors, or is it just kind of coincidental because the rate counts are going higher? You know, if you have higher rates, you're going to have more deaths. People have been a little bit more lax on the NPIs. So is it just kind of a coincidental thing, or are these mutant viruses actually more transmissible?
Yeah, I want to take that one. It's a great question. And this question has been sort of put in several, different discussion forum where there's some evidence that the fact that the new variant, like the UK variant, basically overran all of the other previous variants suggest that there's an advantage in transmission. So that's sort of an epidemiological thing. If you have two variants competing for the same population and you see one becoming more and more common, one of the likely explanation is that it's more transmissible. So there's sort of an indirect conclusion. There's also evidence of a higher viral load in patients with these new variants. When they compare the CT values of some of the patients with the old variants, with the Wuhan, the original, and those with this mutation, including the 614 and the really variants of concern like the Brazilian and the UK variants, they seem to be more transmissible and they seem to have a higher viral load. And they're trying to find explanation. It's a little bit more difficult to find why that is happening. They think that the changes in the spike protein produces more conformational changes in the spike and makes it more available for the receptors. But I think that's a little bit more complicated to understand. But there is both epidemiological, clinical, and also some basic science sort of explanations to understand what there's more transmissibility. Regarding severity, at the beginning, the groups in the UK actually published that the UK variant seemed to be more severe, but there have been two publications recently which basically have put that in doubt. They actually compare patients with and without the UK variant, and they couldn't find really, measures of severity when they look at a more specific hospitalized population with both, with either the UK or some of the original variants. So I think transmissibility is accepted as that it occurs, and severity, we're still not sure that it's more severe, that any of these variants are really more severe. What the Brazilians are saying is that it's affecting younger population, but we don't really know if it's sort of a consequence of vaccination of older groups. They're still looking into that data.
Great, thank you so much.
Great, thank you so much, Nestor. That's super helpful. I'm going to go ahead and just turn it back over to Joanna for further questions.
Great. Thank you, Carla, so much. Thank you guys for all these amazing questions today too, and for the Hub team for providing all these kind of evidence-based and evidence-guided answers. There's a question from Dr. Yehuda Pat about the Indian variant and how the vaccine might affect that, Nestor. And then I think Dr. Mertz has a question about a physician from Rutgers who died over in India, who had been fully vaccinated in the US, and wanted to see if you could address that as well.
Right. I haven't really seen any papers on correlation with the so-called Indian variant, which is the B1617. I wrote it down here because there's so many numbers. I'm going crazy with all these numbers. So the 617, which is the so-called Indian variant, has the E484 mutation, which is one of those escape mutant, mutations associated with immune escape. But I haven't really seen any graph comparing, level of neutralizing antibody with the so-called Indian. I think it's a bit too soon. We'll probably see it in the next few weeks. And I've been waiting for the pre-publications, but I haven't really seen it. It may be out there, but I do not really know how the vaccines. And I heard about this physician who was fully vaccinated. I think he was in the 80s, so that he was 80 years old. So that may be a factor. And there's definitely breakthrough infections, even without variants. There could be breakthrough infections. We know that there have been a few thousands of breakthrough infections in the United States. So it's possible. But it's also possible that he was infected with a variant that was not adequately controlled by the immune response to the original vaccine.
I saw something online about him, and it did say that although he had COVID, he was never severely ill. And so the vaccine did seem to protect him from severe illness. He had underlying heart disease, and in all likelihood, the COVID precipitated the heart attack, but he did not die from the severe COVID. He died from his underlying condition that was brought out by it. So the vaccine does seem like it, at least in part, did what it was supposed to do.
Thank you. Thank you, Nestor. Thank you, Leslie. Maria Cristina Garcia has a question about the vaccines against the P2 variant from Brazil. And I think you've mentioned you've kind of discussed this already. So I might go on to, excuse me, excuse me. And then Deborah Hill mentioned, Deborah Hill also questions about guidance about people who, we have received guidance that those who are fully vaccinated 2 weeks out to 3 months out would not be considered a close. Oh, Deborah, do you want to maybe unmute and ask your question? I thought it was a different type of question, but I don't think we've addressed this.
No, yeah, sure. Thank you. So we've been given guidance as school nurses and others that folks who have been fully vaccinated, which means 2 weeks out, have 3 months where they are not considered a close contact. But we have so many people now who are beyond the 3 months. And I've been looking around and I'm trying to figure out what is the guidance that we give to folks who are over the 3-month mark. Are they still considered no need to quarantine, not close contact? Do we have any word on extension of that time? That's what does that make sense?
Yeah, that's a great question. I don't think we have the answer yet. I think the CDC is waiting for more data on the durability of the protection. We saw some data from the phase 2 of Moderna that at least went out to 4 months, but we haven't really seen anything beyond because people have been vaccinated just, in the last three or 4 months. But you're right, there are people who were vaccinated late December, early January, and except for those who participate in clinical trials, the real life vaccination started in January in most places. So yeah, we're 5 months out. We need new guidance on this, how long the protection is going to last. I have heard about the so-called booster, that we need a booster at some point, maybe at the 6-month point or something, but we still need more data. And I think the CDC is like scrambling to find more evidence of how long the protection really lasts to be able to extend their recommendations on when a person is fully vaccinated. If you're 5 or 6 months out, are you still fully protected or not? That's a great question.
Thank you for that great question, Deborah. Kim Joy has a question, Nestor and Leslie, about a patient that she had that had this significant amount of swelling on her face and arm and hand after the first vaccine. Anyway, Kim read that if the patient were to take an ACE inhibitor, that it might prevent any swelling, and wondered if you read anything about this being evidence-based or evidence-guided.
No, I have not. Interesting comment, but I have not.
Leslie, any?
I haven't heard anything either.
Okay, thank you. And then this maybe is for Cecilia. Thompson, do all labs have assays available to detect all the current variants? It's a question from Young-Key Markham.
So here I can answer for Tricor. Here at Tricor, we are able to detect all of the major variants that are circulating in the US. We're in constant contact with our test and assay manufacturers to determine that. That being said, I don't know about every lab having that same communication, but I would hope that they are doing the same as we are.
Thank you, Cecilia. Just wanted to remind everyone that about 2:47, the CME link went into the chat as well. Aline Gush, do you want to unmute and ask your question? Mini case?
Okay, sure, thank you. So this gentleman is 64 years old, and he didn't have any underlying skin problems that we know of. He hasn't had a rash in the past. He has a very widespread rash that is covering most of his body, and it's the worst on his chest and upper back. It's somewhat rough and pebbly textured. There's been some weeping at times, and he was given a course of oral prednisone a couple months ago, and it was 3 days and it wasn't tapered over the days, and he became quite ill after that. The rash came back. He said that he was given another course of prednisone, but then they tapered it much more gradually, but he was still somewhat ill. So that's run its course. We don't really have that to offer him. I've just started treating him with acupuncture, and we had some improvement so far. I'll be seeing him again today. But I hadn't heard of anyone having a rash that lasted like this and was so widespread. And it's been very itchy and had a lot of heat the entire time. So I wondered if people have seen that.
And this is after vaccination. I'm sorry, after vaccination, the rash?
Oh, I'm sorry, it was after his second shot of the Moderna. The first shot was uneventful. So he had the second one on February 19th, and he still has the severe rash, just as severe.
Yeah, no, I haven't seen, and actually I review a paper here a few weeks ago about the 12 cases of like rash associated with the mRNA vaccines, but they were really mild. They were like localized in the elbows or around the area of injection for a few days after vaccination. But I don't remember seeing these or hearing a description of such a severe rash. I don't know if maybe some of the primary care provider, because I'm an infectious disease, so I usually don't see the patient in the communities, but maybe somebody else have seen this more.
Leslie, thanks, Nestor. Leslie, have you seen anything like this?
I have not. Aline actually sent me a picture of the rash, and it was a very impressive rash. Of course, we don't know 100% it was due to the vaccine, although certainly timing wise, it would make sense. One thing I did recommend was at least it's worth sending it into the American Academy of Dermatology as a registry for post-vaccine rashes that they're sort of, and I talked about it, I think last week or the week before, and it's worth sending it into that.
The other thing is, Leslie, we have a dermatology echo too on Fridays,
wow. Okay.
on Fridays at noon here. And if you're in New Mexico, that might be something to consider, as they might see some dermatology, sequelae of the vaccinations. That's a possibility. Maybe I could ask Holly, who's our program coordinator, to maybe send you the link. That would be great. Great. Maybe we have time for kind of one more question, if that's okay. Cynthia Settles has a really great question, and might just ask kind of everybody in our virtual room. She says, as we open up more, what are other offices doing to see patients? I'm a private pediatrician. We have HEPA filters in our rooms. We currently see patients with COVID symptoms in their car. The whole office is vaccinated, and my concerns are for the parents and kids coming in after, and just kind of want to get a gestalt about kind of what you guys are doing. Are more and more of you seeing your ambulatory practice? Are you opening up your ambulatory practices? I know we don't do this, but might you just chat in if you're opening up, type in yes. If you're not, say no.
I'll comment that we're seeing about a third of our patients in clinic at this point, and about 2/3 are still telehealth. We're doing pretty much the same things we have had since the pandemic started. We have someone screening at the front door, and it's amazing how many people don't think the cough and fever actually apply to them, and get back in the room and they're like, oh well, yeah, it's just my usual allergies. And it's like, ugh. But the HEPA filters, and we are very picky about the masks. Everyone has to wear a procedure mask if they come in with a cloth mask, they're given it. And so, and we have distancing and have, but it is a little scary.
So most people, thanks, Leslie. Most people are saying that they are seeing patients more and more in person right now. Some are saying that they're just seeing patients. Elaine says that they're still being quite conservative. So my sense is it's probably going to be opening up more and more. And thanks, Holly. Holly Lovely just sent the dermatology echo tele registration. So fantastic. Thanks, Holly. Thanks, Leslie, for that. Just wanted to let you know we'll hold on to the questions we didn't get to. We have about a minute left. We do have a few more echoes that I wanted to tell you about before the end of the call today. We have a first responder echo at 2 p.m. Mountain Time, 4 p.m. Eastern Time. It's with Jennifer Weiss. She runs Serenity Mesa Rehab Center for patients in recovery from all substance use disorder. She's a fantastic speaker. She's going to talk about resiliency related to substance use disorder, which has gone up about 20% in the United States since the COVID pandemic hit, on This Thursday, we have the Indian Health Service Mental Health and Resiliency, although it is open to everybody. And Carla, do we have the critical care echo this Thursday, or is it next Thursday?
Yeah, thanks, Joanna. It's next Thursday, May 20th, and it's on COVID-19 in children.
Fantastic. So that'll be a great talk. Wanted to thank Dr. Sosa. I want to thank Dr. Hayes, Dr. Thompson, and of course, Dr. Thornton, and primarily all of you guys for coming onto this call every week. And we'll see you next week. Thank you.